Veronica's present focus lies in the implementation of integrated models of care and value-based initiatives that can be translated across national and international standards of healthcare, with various projects that have been granted quality awards and nominations for New South Wales Health Awards. She currently develops, coordinates and implements mixed methods research and evaluation projects in the South Western Sydney Integrated Care Collaborative and Better Value Care portfolios. Please welcome Veronica. She'll be presenting on learnings from implementing telemonitoring in South West Sydney.
Thank you very much for that introduction. Can everybody hear me okay? Okay, perfect. So I'm here to tell you about telemonitoring and how we've been implementing and developing the whole model of care for South Western Sydney. This project, the LITE, is just one of our many projects that we have been running in regards to research. So if you want to have a little bit more of the understanding of the whole history of it, we also have a poster outside, number 19, the history of telemonitoring. And there's going to be yet another presentation regarding this model of care about the patient experience and on-ground experience from our nurses. So, LITE. We had a project implemented a few years ago, and we realized that most of the times when we're talking about telemonitoring, and I'm saying telemonitoring, not telehealth, telemonitoring, we know what it can do. We know that if we have patients on telemonitoring, we can have early detection, we can assist with reducing the admissions to hospital and even prevent hospitalizations and provide a much better care in the community for our patients. However, when we go into the nitty-gritty of it, we really don't know how, not how it works, but how to implement it. So, and the beauty I see from telemonitoring is when you have a flexible model that can be adapted to the needs of your community and your region. So we really just wanted to know how and why. This is pretty much, the LITE is pretty much a qualitative research, but as I said, it's just one part of the whole telemonitoring. So the background is, we selected a specific region across the southwestern Sydney because it had huge health needs requirements. The population is a rural, remote area. There are no public hospitals or private hospitals in there, and there's a high demand for a fast-growing community. So in 2015, we started with 20 telemonitoring devices. However, right now there's over 100. Across the district, yes. And we also did, with these 20 telemonitorings, we did a retrospective analysis. The publication is out. If you want to look into it, you can use a QR code. It was pretty much just to see what was coming out of it. Now, out of it, we already knew what the data is saying and how the patients are utilizing it and how the GPs are seeing value in it. But with the LITE, we really just wanted to know about the challenges and the lessons from implementing telemonitoring. And at the same time, we also wanted to know what are the possible solutions and what else can we do so that we can bring this model into a much better adaptable model for our community. So all our programs and all our research always have a program logic model. We identify the themes for semi-structured interviews, and that helped us out with identifying the potential participants. Obviously, it was a purposive sampling because we already knew who the implementers were, and we definitely utilized people from all levels of the management of the program, okay? Managers, administration, clinicians. We have another project running right now with the GPs, interviewing the GPs, and then we're looking into another one doing financial and consumer, as in the patient. So perspectives, outcomes. We also did some literature review, not only across Australia, but also at international level, what the differences are with different models of telemonitoring, again, not telehealth, and all the relevant documents that related to these telemonitoring initiatives, in this case, for for our district. And of course, being integrated care, we compared it and did analysis against the framework, New South Wales Integrated Care Strategy 2014. Now, this is another one of our studies. We noticed from the first evaluation, we noticed that most of what was coming out was the need and the importance of involvement with the general practitioner. So we did a focus on having the GP integrated into the model of care because the coordination was much better to have a GP governance. So if you look at the model of how we recruit our patients, we definitely have our client pool. Does it work? No. Okay. So we have our clients, and then we do a pre-selection, and then we definitely go first with the GP, and we engage the GP, and the GP consents. And then after the GP consents, we go and we get the patient onboarded. Why do we get the GP? Because the GP has a clinical management of it, and they select what type of scheduling and what type of measurements they will be doing and how often. So our model of care, it looks a little bit complex, but it's quite simple, and it all revolves around our patient. So we have our patient at home, and we have our general practitioner, okay? Both are already engaged. We give the telemonitoring devices to our patients with the plan by the GP. They do their scheduled measurements, and they get uploaded to the cloud. We have a team of clinicians looking into these red, yellow, and green traffic light systems. And whenever needed, or whenever there's a yellow or red, they will contact the GP, and they will also contact the patient directly. If needed, the patient will go back to the GP instead of, obviously depending on what type of alert it is, they either go to the GP or they have a different type of intervention, or the GP assesses and makes changes on the clinical management of the patient, and the clinical monitoring team can assist with implementing these changes. Then we also have our community nurses. Now, these are the stars of our project, because without them, we wouldn't be able to have as much GP engagement and patient monitoring. Whenever needed, the clinicians that are monitoring all the readings also communicate directly with our community nurses, and they get to communicate or go and see directly the patients and the general practitioner. So we have a very flexible and open communication between these four people: the telemonitoring team, the community nurses, the GPs, and the patient. If anything were to happen, of course, the patient will go to a hospital, and out of there, both the GP and the community nurse will also have the notifications. And it's very much a flow on and flow back process with this model. What are the outcomes? So we wanted to know the barriers and facilitators. So definitely at the beginning, we started getting, of course, staff and resources. The project started with 20 in just one community. Right now, it's rolled over across most of the LHD in at least 6 different areas. And we still have not as many community nurses to help us out with this. And of course, there's an issue with equipment, not enough devices. However, we have found that the best thing that everybody is saying is the GP governance. So because we have the GP involved at every step of the whole model of care, we're getting really good feedback, and the patients are being taken care of quite well. We have coordination of care. It provides support. And another thing that my colleague can tell you is the partners' engagement. So some of the times, even the partners have seen a whole lot of changes in how their loved ones are being taken care of and the quality of life that they are living. Because even the partners see that because the patient is on telemonitoring, the carer or the family member, they seem to have even more free time to go and have a coffee with a friend, things that they're not used to anymore, because being a lifetime carer for someone with chronic conditions. These are some of the quotes that we have been receiving from all the participants. Not all of them are beauty, of course, because we still have other things that we need to fix, I would say to fix, but it's just enhancement of the model so that we can actually roll it all across the whole LHD with appropriate support and staff support. But the idea is just like any other project planning, we keep implementing, we keep evaluating, we keep getting feedback, and we keep making changes and adapt the model. And I just want to acknowledge all the participants that have been, all the collaborative organizations that have been helping us getting all of this through. And if you want any more details, feel free to contact us. Thank you very much.
I'd like to invite some questions from the audience for Veronica.
So I don't know if there was one of those quotes. At the beginning, when we started, we owned them, we bought the equipment. Very soon we realized that was not a good investment, because equipment, like any other type of software, runs out of validity. So we definitely needed to go into a different type of contracting with the telemonitoring agency. So we have a specific service agreement with them, and we rent them out, and they provide along, as part of the service with the contract, all the updates for the software, any type of troubleshooting, any type of maintenance, and if we need to, change it because it's out of date and they're coming up with new technology. For example, we had different type of devices. So we had a tablet that was very rustic for those who are not very techie savvy. It only had like 2 or 3 buttons, and then from that we changed into one that had a video conferencing facility, and now it's even on the phone. So yeah. Who's your provider? Poster 19.
Poster 19. The plug. Do we have any more questions?
It's probably early days, but how long do do people have the telemonitoring? What's the average sort of length of duration?
So that's another thing that has been changing. Telemonitoring, as many know, is usually given to the patients in chronic conditions at a later stage, and they usually stay on telemonitoring either until their disease progresses to a point that they cannot really do the measurements anymore, or the patient, end of life, or they go into palliative. In this case, that's how we started the model, with those 20 telemonitoring devices. But we realized, and I think it was in one of my quotes, that if we get the patients at an earlier stage, we're impacting on their self-management, which is yet another of our research projects too. So, yeah.
Is there any funding for the GPs, or do they just fit it into their workload as best they can without any additional funding?
So the project that we're running right now with the general practitioners, we are seeing how much workload it's giving them extra, if any, depending obviously on how many patients they have onboarded. We have been suggesting, and they've been suggesting also a few other plans. Currently is provided by the LHD at no cost to the GP.
Veronica, just a question on, thank you for a nice presentation.
Thanks.
I saw the GP engagement, you had the consenting process engaged early. Could you tell me how that engagement has evolved and how many patients do you have at the moment?
So from the beginning, the model started with a whole lot more engagement from the community nurses. and it revolved very much around the community nurse coming and going and being the point of contact. We noticed that the governance was not sustainable because the GP wouldn't really understand what was happening with the patients all the time. We saw that it was a clinical risk for the patients, so we definitely need to go back into the GP engagement and GP governance. So all of our community nurses go out into across the LHD, Southwestern Sydney LHD, we have 920 plus GPs. Right now, how many do we have? Close to 200?
Yeah,
about 200-ish already consented into the program. And patients, because they come in and out, in and out, in and out, I think we've gone through already more than 80 patients, easy.
Are there any last questions? No? Right, join me in thanking Veronica.
Thank you.